I am Dr. Nishi Roshini K, Professor and HOD of the Department of Obstetrics and Gynecology, Government Medical College, Thrissur. I will be talking on abnormal uterine bleeding or AUB in adolescent, solving the period puzzle. The adolescent period, as per WHO, is between 10 to 19 years, and after attaining menarche, the normal menstrual cycle is between 21 to 45 days, and the bleeding lasts between 2 to 7 days. The mean is 5 days. I lose about 30 to 40 ml of blood, and usually the pad is changed every 3 hours, and usual number of pads per day is 3 to 6 pads. So, how will you assess that this is an abnormal uterine bleeding? When there is a change in the cycle length, the duration, the amount of bleeding, the cyclicity, we call it as abnormal uterine bleeding. How will you assess it is a heavy menstrual bleeding or excessive bleeding? Suppose she loses more than 80 ml of blood and changes pads every 1 to 2 hours, and if she has to wake up at night to change the pads, or she is soaking her undergarments or clothes by blood, and she has anemia, and she has symptoms of anemia like irritability, headache, and she is moody, depressed, and she most of the days she is absent from schools, and she has verbal cognition defect, and she is not able to concentrate, and she is also not interested to take parts in sports. The abnormal uterine bleeding may be absence of bleeding, irregular bleeding, heavy bleeding, or bleeding in between periods. Coming to the causes, the structural pathology that is commonly seen in reproductive age group women is seen only in 10% of the adolescents. The most common cause of bleeding in the adolescent is ovulatory dysfunction, AUBO, or anovulatory bleeding due to immaturity of a hypothalamic-pituitary-ovarian axis. PCOS is another cause. The hypo or hyperthyroidism, hyperplastinemia, bleeding disorders, pregnancy, pelvic infections due to tuberculosis or STI medications. Coming to the bleeding disorders, the commonest bleeding disorder seen in adolescent period is von Willebrand's disease, factor 7 deficiency, immune thrombocytopenia, platelet function disorders like thrombocythemia, thrombocytopenia secondary to malignancy like leukemia, or as treatment for malignancy are the other causes of abnormal uterine bleeding. The assessment of the blood loss is very important. History is important. From the history you can assess the blood loss from what I described earlier, or pictorial assessment of the blood loss is also possible from this chart. So nowadays many children, adolescents who are using a menstrual cup, they can get an amount of bleeding. Otherwise, if they are using tampons or pads, depending on the staining of the pads or tampons, you can score. A lightly stained pads or tampon is given a score of 1. How many pads you have used is multiplied by this 1. If a moderately stained pad or tampon, you have to give a score of 5. Depending on the number of tampons or pads used, you multiply by a score of 5. Also, you can a score of 10 is given for a fully soaked tampon, and a score of 20 is given for a fully soaked pad. Depending on the number of pads, you multiply by that factor. Also, point is allotted to the depending on the size of the clot. A 1 point for a small clot, and 5 point of a clot that is larger than 1 inch or 2.5 centimeters, and 5 point is also given for an episode of flooding. So add all these points, and if the total score is 100, it means that the adolescent has heavy menstrual bleeding. We'll come to the case scenario. A 16-year-old girl has come to you with a history of profuse bleeding for the past 12 days. She has attained menarche at 14 years of age. She has irregular cycles, and she is also complaining of tiredness, irritability, and inability to concentrate. How will you evaluate? As said earlier, ovulatory dysfunction, AUBO due to the hypothalamic-pituitary-ovarian axis immaturity is the most common cause. So you all know, the first year of menarche, 50% of the cycles are anovulatory. So a girl who's attained menarche less than 12 years, she may attain ovulatory cycle by 1 year. If she attains menarche between 12 to 13 years, she may establish an ovulatory cycles by 3 years. If she attains menarche above 13 years, she may take 4.5 years for the cycles to become ovulatory. So the later the age of menarche, more the number of years are sent in anovulatory cycles that she may experience bleeding. So in anovulatory bleeding, there is no ovulation and there is no progesterone. So the unopposed estrogen will act on the endometrium. The endometrium will thicken until it sloughs. The endometrium becomes excessively vascular without stromal support. The fragility and irregular endometrial bleeding occurs. So what is the feature of an anovulatory uterine bleeding? It is the irregular periods. There is absence of premenstrual symptoms. There is absence of dysmenorrhea. The cycles are very heavy. And hypothalamic dysfunction can also occur if you are doing excessive exercise. It's psychological stress, malnutrition, chronic disorders, acute weight loss occurs, or in obesity. Heavy menstrual bleeding that occurs at regular intervals. At the onset of menarche, you should think of bleeding disorders. But think that this anovulatory cycle may occur simultaneously. Her cycles become irregular and heavy. So, in irregular heavy bleeding also, you should think of the possibility of bleeding disorders. The less common causes of heavy menstrual bleeding may be systemic disorders, hypothyroidism, hyperprolactinemia, or structural causes. As said earlier, the causes of AUB should be ruled out like pregnancy, thyroid disorders, PCOD, bleeding disorders, hyperprolactinemia, trauma, STI, medications like steroid, phenothiazide, tricyclic antidepressants, anticonvulsants, and anticoagulants. But you should always remember that a girl attaining menarche for 3-4 years, the cycles may be irregular, so never label PCOS if she has irregular cycles with hyperandrogenism. She should be labeled at risk PCOS, and she has to be reevaluated 3-4 years later whether she is developing PCOS or not. The clinical evaluation include assessment of hemodynamic stability, that is evidence of tachycardia, hypotension, features of anemia, and also any features of bleeding disorders. Should rule out pregnancy status, think of all the differential diagnoses enumerated and evaluate accordingly. The history is very important. It should be done with and without the presence of the patient's caregiver. The menstrual history is better taken in the presence of caregiver because the caregiver may be able to give details rather than the adolescent. Age at menarche, because we said age determines whether how many years are taken for the cycles to become ovulatory. The menstrual pattern is also should be taken. The history of events that coincided with the change in menstrual pattern, that like stresses, then acute weight loss, all this has to be thought of. And when did the bleeding start, whether first period or sometimes later, also should be asked for. The sexual and reproductive history should be taken without the presence of a caregiver. Ask for a sexually active girl, should ask about contraception, STI, and also any current symptoms of STI like if she has fever, discharge, etc. The past medical history will give a clue as to whether she has bleeding disorders like bleeding epistaxis, bleeding on dental extraction, or any epistaxis or any easy bruising, ecchymosis. And also the medication history should be asked for. The family history will give a clue as to whether there is any bleeding disorders. The social history also is important. And the physical examination should include height, weight, taking a BMI, vital stats, signs like evidence of tachycardia, orthostatic hypotension. Also look for any pallor and also evidence of petechial ecchymosis and swollen joints, which may indicate a bleeding disorder. The staging of thelarchy and menarche is important. Look for signs of hyperandrogenism, including hirsutism, acne, clitoromegaly. If there are any signs of insulin resistance like acanthosis nigrans should be looked for. If there is signs of hyperandrogenism with insulin resistance, it may suggest polycystic ovarian syndrome risk. And also abdominal examination should be done to rule out any abdominal masses. Look for hepatosplenomegaly. Genital examination, look for any evidence of discharge. The laboratory investigation include complete blood count, evidence of iron deficiency, anemia, thrombocytopenia. Also, we will give an idea about the platelet count and also WBC count. Urine pregnancy test should be done to rule out pregnancy because an ectopic pregnancy, molar pregnancy, and abortion can present with bleeding abnormalities. Assessment of ferritin will help to identify anemia earlier. Also, thyroid function test will rule out hypo or hyperthyroidism. Serum prolactin estimation should be done if there is galacturia or any headache is present. Screen for STI if indicated. If hyperandrogenism and insulin resistance, investigate for PCOS. The coagulation panel include testing PT, APTT, fibrinogen and platelet count. The PT will be prolonged in factor 7 deficiency. APTT will be prolonged in factor 8, 9 and 12 deficiency. And also both may be prolonged in 2, 5 deficiency. The peripheral smear will give an idea about the type of anemia, about a platelet and also of WBCs. Ultrasound examination will give a clue as to the uterus, the endometrial thickness, the ovaries, as well as assess the hepatosplenomegaly. If PID is present, you should look for any evidence of tuberculosis, and also the discharge can be sent for nucleic acid amplification test for gonococci and also chlamydia. If no discharge and if you suspect PID, the urine can be sent for nucleic acid amplification test for gonococcal and chlamydia. Von Willebrand's panel include examination of the von Willebrand's factor antigen, the von Willebrand's factor activity and factor 8 activity. When you want to evaluate for the von Willebrand's panel, you should take the blood for estimation of the panel prior to any blood transfusion and prior to the administration of the estrogen products, because estrogen may increase the production of von Willebrand's factor and resulting in falsely normal values. Also, the hemodynamic instability. If the patient is presenting with hemodynamic instability, which is very rare, usually it is identified by tachycardia and orthostatic hypotension. In such cases, you should arrange blood transfusion. And the severity of classification of abnormal uterine bleeding depends on the hemoglobin value. It is said to be mild when the hemoglobin is equal to slightly above 12 gram, but maybe between 10 to 12 also. You may remember that in adolescent the HP target is 12 gram percentage. It is moderate bleeding when the hemoglobin is not 12 but it is above or equal to 10 gram percentage. It is severe if the hemoglobin is less than 10 or may show features of hemodynamic instability in the form of, and that is giddiness or orthostatic hypotension or tachycardia. The goals of management of anovulatory uterine bleeding include hemodynamic instability, if present, arrest of bleeding, correction of acute or chronic anemia, and return to a pattern of normal menstrual cycles and prevention of recurrences. So coming to the management of mild bleeding, you can observation and reassurance is needed. Hemostatic agents that are used to control bleeding are tranexamic acid and NSAIDs. The tranexamic acid can be given in the dose of 1300 mg TID for 5 days. NSAIDs can be given 500 mg TID for 5 days. And hormone therapy also can be started to stabilize the endometrial proliferation and promote cyclic shedding. Which are the hormones used? Can be progesterone alone or combined oral contraceptive. The progesterone preparations usually used are norethindrone acetate, medroxyprogesterone acetate, or micronized progesterone 200 mg. We usually use norethindrone acetate and medroxyprogesterone. You can start with a dose of 10 mg and medroxyprogesterone 10 mg and norethindrone acetate as 5 to 10 mg, and you can give it for 21 days. Oral iron is given 60 mg per day, and on withdrawal of those hormones she will get a withdrawal bleeding, and you can restart on the third day or so. And menstrual calendar is maintained and review at 3 months. When you start the hormones on the third day, you can start it this medroxyprogesterone 10 mg, norethindrone 5 to 10 mg, or micronized progesterone 200 mg for 10 to 12 days and wait. If there is moderate anovulatory uterine bleeding, along with these hemostatic agents, oral iron, you have to start hormones to stabilize the endometrial proliferation and shedding. Oral progesterone or combined oral contraceptives can be used. When you use combined oral contraceptive pills, the estrogen content should be 30 microgram of ethinyl estradiol. Usual combination with levonorgestrel will be better. You can use other combined oral contraceptive preparations also. And how long will you give? If the bleeding is severe, moderate, you can start these tablets. Oral progesterone, norethindrone 5 to 10 mg 3 times or 4 times, and then you taper over a period of 21 days. That is, weekly you can taper the dose. Or if you are starting combined oral contraceptive pills also, you can start in a dose of 3 times or 4 times or BD, and you can taper the dose in weekly, and you can give it for 21 days. And you also can start oral iron 60 mg BD daily or on alternate days, and menstrual calendar has to be maintained. In severe anovulatory bleeding, you have to admit the patient if the hemoglobin is less than 7 and she is not profusely bleeding, or hemoglobin is less than 10 with profusely bleeding, or to give packed cell transfusion to keep the hemoglobin above 8. The hemostatic agent simultaneously can be used, that is tranexamic acid tablet 1300 mg 3 times daily for 5 days. Also, acute bleeding can be controlled by tranexamic acid IV 10 mg per kg weight, not more than 500 mg per dose. You can repeat 8th hourly. And aminobutyric acid also can be given 5 gram as a loading dose IV, followed by 1 gram per hour for 8 hours. Desmopressin is also can be given in desperate conditions, 0.03 microgram per kg weight. The progesterone only pills, as said earlier, norethindrone acetate medroxyprogesterone can be started 3 times or 4 times daily and can taper the dose. Similarly, combined oral progesterone can also be started 3 or 4 times daily to arrest bleeding. Then you can taper the dose weekly and give it for 21 days as the single dose therapy for 21 days. Suppose after 24 hours of giving these progesterone only pills or combined oral contraceptives, the bleeding is not controlled, you can give intravenous estrogen primarin, equine estrogen 25 mg IV 4th hourly or 6th hourly. Never give more than 6 doses. After that, you can switch on to combined oral contraceptive pills or progesterone only pills, and oral iron has to be given. What is refractory uterine bleeding? So you have treated with hormones and anti-fibrinolytic agent, still the bleeding continues. You have to evaluate under anesthesia for other causes, trauma, foreign body, and also you have to do an endometrial sampling also. The maintenance therapy is also very important, and the maintenance of the menstrual calendar also is important. Check hemoglobin monthly till it is more than or equal to 10, and then every 3 to 6 months until the hemoglobin is above 12 gram percentage. Our target is hemoglobin above 12 gram percentage. The oral contraceptive pills can be given cyclically starting from the third day of the period for a total of 21 days for 6 months, and then stop it and reassess after 3 months. LNG IUCD is another option to control as bleeding and have a maintenance therapy. The take-home message is abnormal uterine bleeding is a stressful state for the adolescent as well as the parents, and the commonest cause is anovulation. A thorough evaluation is crucial for the accurate diagnosis and treatment. The routine pregnancy test is always essential. Bleeding disorders, sexual abuse, trauma, STI, PID, medications all should be thoroughly evaluated. And anemia correction, hemostatic agents, and hormone therapy is the mainstay of treatment. Thank you.